Alterations in cardiac output and tissue perfusion, valvular disorders. Heart structures help maintain the normal function of the heart. There's 4 cardiac valves: aortic, mitral, tricuspid, and pulmonic. These structures can be affected by malformations at birth, inflammatory and infectious disorders, age-related degeneration, structural damage after MIs, or injuries from intracardiac procedures. On the left side of the heart, we have the aortic and mitral valves. On the right side of the heart, we have pulmonic and tricuspid valves. So the aortic valve has 3 cusps or leaflets. Aortic stenosis is caused by the narrowing of the opening in the aortic valve cusps becoming stiff and rigid, causing the valves to not open properly. Then we see muscular wall of the left ventricle enlarging and thickening in response to that stiff calcified valve, and it causes insufficient blood flow to the myocardium and other organs, and it can lead to left-sided heart failure. In the older adult, narrowing of that aortic valve may be a degenerative change, whereas in the young adult, it's usually caused by a genital defect. Other causes can include rheumatic carditis and infective endocarditis. These clients may be asymptomatic, but some experience dyspnea and fatigue during activity, dizziness, fainting, angina, a carotid pulse that feels weak, and an S2 heart sound being split, sounding something like lub-ti-tub. Diagnostic findings: we may do a chest x-ray, an echocardiogram, an ECG, and cardiac catheterization. To manage it, we would try to maintain adequate cardiac output through the use of digitalis, diuretic, sodium restriction, antibiotics, nitrates, and beta-adrenergic blockers. Surgically, we may do a balloon valvuloplasty or an aortic valve replacement or a transcatheter aortic valve replacement. As nurses, we need to monitor symptoms, explain the purposes and techniques of the diagnostic tests, administer prescribed medications, institute measures for adequate cardiac output and tissue oxygenation, and potentially introduce fluid restrictions. So the nurse assesses the client diagnosed with aortic stenosis. On auscultation, the nurse assesses a grade 2 heart murmur, and a description of this heart murmur would include a very quiet murmur that can be heard when auscultating the heart. So that S2 heart sound would be split. So there's a definite separation between the sounds of the aortic valve and the pulmonic valve closing. Once again, it would be that lub-ti-dub sound. With aortic regurgitation, the aortic valve does not close tightly and blood can leak backward, and it leads to valvular incompetence. It can be caused by damage to the valve cusps or the papillary muscles, rheumatic carditis, endocarditis, syphilis, age-related stretching or proximal aorta, systemic inflammatory conditions. The use of fen-phen or redux in years past, fluid overload in the left ventricle or high pressure that interferes with atrial emptying. These clients may experience tachycardia or a flushed, moist skin, the water hammer pulse, a systolic blood pressure that's high with a diastolic blood pressure that's low to normal, and a heart murmur. The first symptoms would be palpitations when they're lying flat or on their left side, and later stages would include dyspnea and chest pain. We might do a cardiac catheterization, chest x-rays, an ECG, radionuclide scan, or a transesophageal echocardiography, along with a CT or MRI. These clients may require cardiac glycosides, beta blockers, diuretics, prophylactic antibiotics to help prevent any infections, and they may need to modify their lifestyle. Surgically may require that aortic valve replacement or a vascular graft. Nurses need to prepare the client for diagnostic procedures, monitor their responses, and report changes in heart rhythm and rate, complaints of dyspnea, chest pain, or loss of consciousness, in addition to educating about the prophylactic antibiotic therapy and teaching them how to monitor their blood pressure. For which one of the following assessments would the nurse withhold a cardiac glycoside such as digoxin when caring for a client with a valvular disorder of the heart? The client's heart rate is 50 beats per minute. Digoxin is going to lower the heart rate, and we need to make sure that the heart rate is not too low to start with prior to administration. Mitral valve is going to be located between the left atrium and left ventricle. It is a bicuspid valve. So causes of mitral stenosis would be rheumatic carditis or recurrence of endocarditis. Inflammation will cause a thick, rigid commissure, which is going to lead to incomplete emptying and may form an arterial emboli, pulmonary hypertension, and right-sided heart failure. These clients may experience fatigue or dyspnea after slight exertion, tachydysrhythmias, dyspnea at night, and requires them to sleep in a sitting position, a cough that's productive of a pink frothy sputum, crackles in the lungs, changes in the heart sounds, neck vein distension, peripheral edema, and cardiac arrhythmias. We diagnose through a chest x-ray and esophageal echocardiogram or an ECG. These clients may be on antibiotic therapy and also medications that may help prevent or relieve symptoms of heart failure, require a daily aspirin or anticoagulants to help prevent clots. Surgical management may include a commissurotomy, cardioversion, or a percutaneous balloon valvuloplasty. Nurses need to monitor physical condition, prepare the clients for any diagnostic tests, and provide post-treatment care, along with discharge teaching for drug therapy and reporting of complications. Mitral regurgitation is caused by rheumatic carditis and mitral valve prolapse, damage to papillary muscles, and impaired myocardial function after an MI. With mitral regurgitation, we're going to see blood flowing backward into the atrium during ventricular asystole, and it leaks into the left ventricle during atrial diastole. It can also cause cardiogenic shock. These clients may experience chronic fatigue, dyspnea on exertion, palpitations, a diminished S1 heart sound, hypertension, tachycardia, and a blowing murmur. These clients can be diagnosed through a transthoracic or transesophageal echocardiography, chest radiography, and radionuclide angiography or an ECG. We manage it with angiotensin-converting enzyme, angiotensin, receptor blocker, digitalis, calcium channel blockers, beta blockers, and antidysrhythmic drugs. Surgically, we may do an intra-aortic balloon pump, an annuloplasty, or valve replacement. Nurses need to monitor blood pressure, heart rate, and rhythm, assess heart sounds and lung sounds, report signs of left or right-sided heart failure, and educate on those prophylactic antibiotics. With mitral valve prolapse, we see those valve cusps enlarging, becoming floppy, and bulging backward into the left atrium. It is more common in young women than it is in men. It can be an idiopathic cause. We may also see a rheumatic carditis or an inherited connective tissue disorder or coronary artery disease. A mitral valve prolapse syndrome is also considered an autonomic nervous system dysfunction. These clients may be asymptomatic. They may also have chest pain where the angina does not correlate with physical exertion. The duration might be prolonged and it's not relieved easily. These clients may also experience palpitations, fatigue, anxiety, a rapid or irregular heart rate, shortness of breath, lightheadedness, difficulty concentrating, or a clicking sound during ventricular systole. We diagnose it with an echocardiography or an ECG. These clients may be on an antibiotic therapy, digitalis, beta blockers, calcium channel blockers, low-dose aspirin, or anti-anxiety medications. They may also require a valve replacement. Nurses need to help relieve chest pain, encourage the client to lie flat with their legs elevated at 90 degrees. They should restrict alcohol and avoid caffeinated beverages. And we should also promote adequate fluids, exercise, and monitoring of the blood pressure. So a client has a possible diagnosis of mitral stenosis. Which of the following symptoms would correlate with this diagnosis? Basically, all of the following are symptoms caused by stricture of the mitral valve. Heart failure might be a complication of this disease.